Okay.
Thank you, Marcelo. So when they asked me to give this lecture, actually I didn't understand the title. So I decided to change it from prognostic to pragmatic indicators of lung injury, meaning that I will focus on those parameters that are more or less under our control when we set a ventilator and could eventually have an impact on lung injury, on the different mechanisms leading to lung injury, like overdistension occurring mostly in the non-dependent part of the lung, opening and closing, and of course inhomogeneity that acts like an amplifier of the stress locally. So, since more than 20 years, we know that to decrease the stress is a good idea not to set a very high tidal volume and to limit inspiratory alveolar pressure below a threshold value. And later on, we also understood that, it's even better if we personalize the tidal volume according to the size of the lung that is available for ventilation, that is the size of the so-called baby lung. And this is exactly the meaning of driving pressure, that is the difference between plateau pressure and total PEEP, but is also the ratio between tidal volume and compliance. And compliance can be viewed as a surrogate for the size of the baby lung. So we try to limit driving pressure below 15 or maybe now below 12 centimeters of water. But if we are mostly interested in lung injury, probably we have to focus on lung driving pressure. That is one of the two components of the respiratory system driving pressure or airway driving pressure. So again, if the threshold for airway driving pressure was 15, should be a little bit lower for the lung driving pressure, and data are accumulating showing that probably the upper limit should be around 10 or 12 centimeters of water for the lung driving pressure. And then power, okay? It was very well explained in the previous lecture. So we can measure the energy that is delivered by the ventilator or done by the patient. Each breath as the area of the dynamic pressure volume curve. So there is an elastic and a resistive component. And if we multiply times respiratory rate, we get the mechanical power. That probably is even more important than the energy per breath. And when this concept was applied to a very large pool of data coming from different controlled randomized trial, they found that among the different components of the mechanical power, only two were significantly associated with an increase of mortality rate, driving pressure, and respiratory rate. We have to consider that this finding could be influenced by the data that generated. So it's a statistical analysis. Anyway, the two factors affecting the risk of death in this data set have also a different weight. So it was more important the driving pressure than the respiratory rate. And if you look at the picture on the left, you see that with the relationship is almost linear for the respiratory rate, so the increase in respiratory rate is linearly correlated with the increased risk of mortality, whereas with driving pressure, it seems to be a more faster increase, let's say, similar to an exponential increase. And this could suggest a different approach in different patients according to their respiratory mechanics. For instance, if our patient has a very low compliance and the driving pressure already above the limit, probably the priority here is to decrease driving pressure and try to control hypercapnia by increasing respiratory rate. On the other hand, if our patient has a not so bad compliance, in this case, it's probably better to, and the driving pressure is below the threshold, is below the safe threshold, of course. In this case, it's possible to increase a little bit tidal volume and driving pressure and maybe decrease respiratory rate. So it's common sense, this. These findings also generate some debate that was started right 5 minutes ago, whether to include the area, the blue area, that is the static component of the elastic energy related to PEEP, or we have to compute the mechanical power just including the area of the red triangle, that is the elastic component related to driving pressure. And I think that you, Marcelo, and you, Luigi, you are both right, of course. Why? Because if you look at the intensity of mechanical ventilation, no doubt, you have to include this value. Because it's easy, to say that for the same driving pressure, we are more aggressive if we set 50 of PEEP or 10 of PEEP, because driving pressure is applied on top of PEEP. But it's also true that we know that PEEP may have both positive and negative effects. For instance, if we increase PEEP in non-recruitable patient, we see no change in the amount of lung tissue that is de-recruited. So we have only the side effect, the increase of lung stress and mechanical power. Whereas, if we increase PEEP in highly recruitable patient, we see a decrease of the de-recruited lung tissue at CT scan, and also, and to me it's very important, a decrease of the opening and closing. The amount of lung tissue that is closed during expiration and reopens during inspiration. So in this case, okay, we pay the same side effect, so an increase of lung stress and mechanical power, but we have also a decrease of tidal recruitment, and why not lung inhomogeneity? And John explained how is important and dangerous lung inhomogeneity in the lung. So the net effect in this case could be, I don't know, but could be in favor of an higher PEEP. And yeah, it's very well known and studied, the deleterious effect of opening and closing. There is a progressive deterioration of lung mechanics and of lung injury scores. And it seems that our patients agree with this, no? Because if we set low PEEP in patients with a high potential for lung recruitment or high PEEP in patients with low recruitability, their outcome is very, very poor. These are the findings of Alessandro Protti, again from Milano, the group of Gattinosi, clearly showing that maybe there is a difference in the capability to generate lung injury between static and dynamic stress. So moving from the right to the left in the slide, for the same total lung stress, you observe a worsening of lung mechanics, gas exchange, lung histology, inflammation, when you decrease PEEP and you increase the dynamic component that is driving pressure. These are the three big trials on comparing the high versus low PEEP strategy. They failed, but I think that we can interpret also differently this finding, because mortality was the same. So we can also say that if you want or if you need to increase the total stress applied to your patient, you can do it safely without increasing mortality if you increase PEEP. And this is exactly the meaning of driving pressure, no? For the same total stress, for the same plateau pressure, mortality is decreasing if the static component is increased, if PEEP is increased. And if you increase plateau pressure, if you increase the applied stress to the lung, mortality increases if you don't increase PEEP. And I think that there is also let's say, an explanation why the safe limit for driving pressure is 10 to 15 centimeters of water. No? The conventional way to interpret driving pressure is, this is a way to normalize tidal volume on the size of the baby lung. But maybe there is another explanation why limiting driving pressure is also limiting the lung injury and improves outcome in our patient. And is this one. We know that the difference between opening and closing pressure in the injured lung is about 12 to 15 centimeters of water. So keeping a driving pressure below this value could help in not opening with the applied inspiratory pressure lung tissue alveoli that we are not able to keep open with our PEEP setting. That means that limiting driving pressure could be helpful not only to limit stress, but also to limit atellate trauma, opening and closing. And Gattinoni clearly demonstrated that the relationship between opening and closing and mortality is probably more strict than the relationship between alveolar strain and stress and mortality. The problem is that we usually do not measure opening and closing tidal recruitment at the bedside. How to do it? Some suggestion comes from this experimental study. They had a model of isolated lung, normal lung, but with two different conditions tested, a high and a low recruitability condition that were imposed by keeping a negative versus a positive transpulmonary pressure during expiration. So with a negative transpulmonary pressure, that was the high recruitability condition, with a positive, low recruitability condition. And they tested tidal hysteresis as a function of tidal volume and driving pressure. And you see, when they increase tidal volume and driving pressure, tidal hysteresis increased very slowly in green, when in the low recruitability condition, whereas tidal hysteresis increased in a fast way, exponentially in red, in the setting of high recruitability condition. What is tidal hysteresis? How we can measure at the bedside? Performing a pressure volume curve different from the standard one, that is the full pressure volume curve, is a tidal pressure volume curve. So moving from the PEEP level up to plateau pressure and back. And the question is different. If you perform a full pressure volume curve, we want to measure the potential for lung recruitment in our patient, whereas doing the tidal pressure volume curve, we ask the question whether our PEEP level is able to avoid tidal recruitment. And from a physics point of view, I like this very much. Actually, this is the amount of unrecovered energy. That is the energy that is dissipated each breath in the respiratory system of our patient. I'm going to the last slides. This is just an example of what we can do at the bedside. It's a decremental PEEP trial in an ARDS patient, where we tested PEEP levels from 18, very high level, down to 6. And this is the pressure volume loop performed at each step. Very small hysteresis with 18 of PEEP. Nothing changed in this patient down to 12 of PEEP. You see all the pressure volume loops are almost superimposed. And then as soon as we decrease PEEP below this level, a sudden increase of lung hysteresis was observed. An exponential increase, meaning that tidal recruitment was occurring. So in the end, and this is my last slide, to be pragmatic, we have to limit both stress strain and athlete trauma, playing with tidal volume, trying to control plateau pressure and driving pressure, and of course the total inspiratory energy to limit stress and strain. But we have also to check for tidal recruitment and athlete trauma. To limit as much as possible, we have to select a good combination between PEEP and tidal volume. And to measure this problem at the bedside, we propose to perform a tidal pressure volume curve and looking at tidal hysteresis. And then remember that we have to multiply both the energy times the respiratory rate to get the total mechanical power that is applied per minute, the energy per minute that is applied to the respiratory system, and to get also the proportion of this total mechanical power that is dissipated in the respiratory system. Thank you for your attention.